And I'm going to welcome you all. Welcome everyone to our conversation with Dr. Kailas Roberts. This is our first conversation since July, so I'm absolutely delighted that we've got Kailas with us from Brisbane. You might have noticed we've been chatting about that, and that's why we're at an earlier time today. So, hi Kailas.
Hello there.
So our plan for today is we're going to have a conversation with Kailas. We're going to find out what he does down in Brisbane and the sort of work that he gets involved with. We're going to find out about the book that he's written. And then towards the end, we're going to have a question and answer function. So if you've not been on before, at the bottom of your screen, there's a little Q&A button that you can press. So at any time, if you have a question, rather than write it down or try and remember it, just pop it in the Q&A and then we'll pick that up at the end. Okay. So my name is Emma Smith. I'm the project manager with Empowered Conversations, which is an Age UK Salford project. We deliver communication courses across Greater Manchester. We also offer one-to-one support for family carers, and that's just in Salford at the moment. And since COVID, we've been doing these regular webinars and we have engagement sessions. So we have a disco that was yesterday, and we have a singing group that happens on a Friday. And we also have groups for carers just to offer them some extra support. So that's what we've been doing, and that's what our day-to-day is. I'm always excited when we're having a conversation because this is like my training, Kailas. So I'm really bad at putting myself on training, but by having these conversations, this is my training. So I have this ongoing training for me, which is brilliant. So thank you for that.
Pleasure.
I didn't tell you that when I asked you to do one. Okay, so let's get started. So everyone said hello, brilliant. All right, we've got most of our participants in now, but maybe some will join us. So Kailas, would you please give me a little bit of background? You know, how come you're on the conversation with us today? You know, what's your role in dementia care, please?
Yeah. Okay. Well, thanks for having me on, first of all, Emma, and thank you to everybody listening in and things. It's really nice actually to be able to talk about dementia a bit. And I think obviously I'm based in Australia, and there are differences between sort of dementia care to a certain extent here and in the UK, but there's also a lot of similarities as well. And so I've been sort of involved in the area for about probably close to 15 years now, or 20 years, and then I took a bit of a break and things. But I'm a doctor, so I went through sort of medicine in Leicester University in the UK, and then shortly after that, yeah, thumbs up to Leicester. Shortly after that, I came to Australia. I was briefly in Bolton, actually, so for 6 months doing emergency medicine. And then when I was in Bolton, we were approached by a locum agency who showed us this really nice PowerPoint presentation of why we should come to Australia, you know, with all these golden sandy beaches and so on. And so they hooked me and probably about another 6 emergency doctors in to come over to Australia, basically to fill areas of need. So we were sent to Darwin, actually, which is at the very north tip of Australia, really hot place that a lot of Australians don't want to go to. So I ended up coming over to Australia back in 2000, and my wife's Australian, although I met her in the UK, so there was a kind of extra reason. I've essentially been here ever since, apart from a brief period of time in London and then Wales about 13, 14 years ago. But I trained in medicine, then I trained in psychiatry, and then during my psychiatry training, I did a rotation where I did psychiatry of old age, which I just really liked. I liked working with the elderly, and it just had a much nicer atmosphere around it than acute adult inpatient psychiatry. And so I became interested in that, and then also particularly interested in cognitive assessment, assessment of memory and so on. And so then just kind of followed that path really, and now currently work as a psychiatrist in private practice, which is a bit different here to UK again. So a lot of patients access private healthcare here as opposed to England. But that's predominantly what I do, and I see general adult psychiatry patients, but I also see an awful lot of people with cognitive problems and the elderly with either mental health problems or dementia or both, of course. And I sort of have a bit of varied day-to-day practice. So I'm based in my rooms a couple of days a week, and I'll do assessments of people's sort of cognitive status, assessing for dementia, and also looking at managing the fallout, the difficulties that people encounter with dementia. And then a lot of my time is actually spent visiting various nursing homes around the local area, advising again on dementia and other mental health problems within aged care facilities, and quite a lot of emphasis on, again, managing the behavioural and psychological changes that sometimes accompany dementia and trying to work out the best way forward and things. So yeah, so that's really, I guess, me in a nutshell.
Okay, so can you give me, I don't know, like an example of the, like a patient that you might see or that you're sort of supporting?
Yeah, sure. So there are three, I guess, medical specialties who generally assess cognitive problems. So neurologists, geriatricians, and psychogeriatricians. So I'm a psychogeriatrician, which is the same thing as an old age psychiatrist. And because I've got that background training, I often get to see patients or clients that have mental health problems that are quite a prominent part of what's going on. And so sometimes I will see people who the GPs will refer them to me thinking they have dementia, and actually, in fact, they have some profound depression, or they're terribly anxious or stressed, and so on. So I suppose part of my job is sort of trying to pick apart mental health problems from cognitive health problems, and actually, which can sometimes be very satisfying, because sometimes if it's depression that's the sole cause of the cognitive problems, and then you fix that, then obviously that sort of is a very good outcome for the person that I'm seeing. So I see a lot of people with, I guess, mental health problems masquerading as dementia. And then I see a lot of people who have dementia at different ages as well. So some young onset dementia. I've seen people in as young as their sort of early 50s, all the way through to over 100. So vast kind of span of different ages. So that's a sort of example of somebody I might see in my clinic. And then in the aged care facilities, again, I suppose my typical person that I'd be asked to see is somebody who has dementia, who's quite sort of aggressive or agitated, and is causing havoc sort of in the aged care facility. And that's that's a very tricky one to manage. And often there are different needs. So there's the needs of the person with dementia, there's the needs of the staff who are looking after the person with dementia, who are sometimes worried about their own safety, and then there's the needs of the family who or the relatives, the loved ones, who will have perhaps a different take on things to the staff and will be very against the idea of any intervention that might cause difficulties for the person with dementia, using medications and so on. So those are quite complex, but a lot of that's just about diplomacy, I think, actually, and just trying to provide education to everyone and having conversations that allow everybody to make informed decisions about the best way forward.
So I was interested when you were saying like mental health and dementia. How do you ever pick that apart? How do you work out, is it a mental health issue? Is it dementia? I don't, that blows my mind how you would work that out.
Yeah, look, and that can be really difficult because it's a complex relationship between depression and anxiety, particularly, and dementia. So sometimes dementia and anxiety, like I say, can be the cause of the cognitive problems and there's no dementia. Sometimes they can be comorbid with dementia, so there is dementia, but there's also a mental health problem. And sometimes they can actually be the first manifestation. So I've seen people perhaps over a period of 5 years or so, and they've initially come to see me and they don't have dementia, but they have quite severe anxiety, and it's just tricky to get on top of. And then as time goes on, it has evolved into a dementia. So sometimes the mental health problems are kind of a harbinger, if you like, of later dementia. So this is kind of, there is this complex interplay of cognitive and mental health kind of difficulties. But essentially, my approach to all these things is, if there's any evidence, there's any real suspicion of a mental health problem, then you just have to try and treat that before you come to any conclusion about whether a dementia is present or not. So depression and anxiety do have certain features which differentiate them from dementia. Some of the features are quite similar, sleep disturbance, apathy, lack of motivation, lack of interest. They can occur with both things. But if you see somebody who's really very negative in their thinking, or feeling hopeless, or frequently and persistently tearful, and so on, then there might be red flags that some sort of depression or mental health problem is going on. So yeah, it's a tricky business, but we kind of work our way through it. Yeah. So
within all of that work, you thought, oh, I'm going to write a book on this because I've got all this spare time. I'm just going to write a book. So tell me about that book, and is it relevant for us? We're in the UK, we're not in Australia. So tell us a bit about that.
Yeah, thanks. Yeah, that was funny, really. I like writing generally, and for me, actually, it was a bit of an escape. And people often say that, how did you find time to do it? But for me, it was actually therapeutic to kind of just sit down and just write and things. It's just sort of my happy place, I suppose. That was a good thing. And actually, before I wrote the book on dementia, I wrote a young adult fantasy novel. Which is my genre of choice, and that really it's not available, I'm afraid. I did send it out to some people to try and get it published, but I don't think it was original enough. So I kind of did that, and then I was talking to my wife, and she said, "Look, I think you'd be probably far better off writing something a bit more useful, like a book on dementia, for instance." So that's kind of how it came about. But it was really, I think, informed by my awareness over the last 10 years that the understanding of dementia, at least in Australia, is quite limited. I mean, I'm not sure, it's probably variable in the UK, but here, obviously a lot of people, and they just really wouldn't know some sort of fairly, I suppose what I would say, basic stuff about dementia. And that's despite the fact that there are lots of websites on it and things, but I think sometimes they're just not that accessible. People don't know where to look, they don't particularly trust what they read and so on. So I just thought it would be a good idea to try and write this guidebook, if you like, to dementia that sort of covers a lot of the different aspects of brain health and prevention and treatment and so on. And to answer your specific question about is it relevant to people in the UK, definitely, I'd say. It's funny, it is called Mind Your Brain, the Essential Australian Guide to Dementia, and that was the publishers kind of saying that's probably the best way to phrase it. But I would say that 95% of it is relevant wherever you are. There are some specific chapters on the aged care system in Australia and some of the legal things over here which aren't relevant over there. But everything else is, dementia is a global thing, everybody struggles with it. So so I would certainly say it's relevant to pretty much everyone wherever you are, most of it anyway.
And are you planning just to change one word so that you can get it going in America, in the UK, in France?
Probably.
Just change that one word.
Yeah, I'll just cut out a couple of chapters or get somebody locally to write the equivalent in their country. And I might just actually cross it out with a line.
Yeah, I would just cross it out and say, no, this is not relevant for you. Yeah. Has it been well received? How's it doing? Is it, any people buying it?
Yeah, it seems to be okay. I mean, it's funny because it came out in March and I have no idea really of the sales. Like the only way you can really tell for sure is actually, I suppose, when you get paid some money for it. And I haven't received anything yet because there's this very long delay. So I actually don't really have an idea, but the publishers sort of say, well, judging from the amount of demand from the big warehouse in Melbourne, it sold, a reasonable amount of copies. So I've been quite happy with it, and I think they've been quite happy with how it's been received and things. And I haven't really had any sort of negative feedback about it, and I've had a lot of people said that they've got a lot out of it. So it's been satisfying in that way.
And maybe this is the right time to launch your other story, get that back out now that that you being like a recognised author. You could just slip that sci-fi back out there and see if it works.
Yeah, do you reckon there's much similarity between the two?
You'd be fine. You'd be fine.
Yeah,
now, I know you've got some slides to show us, and it feels like this is a good chance to bring them up and just talk a little bit more about some of the subjects that you cover in your book.
Yeah, sure. Okay. Well, I'll just share my screen.
Look at this, Carolyn. Honestly, you're on it. She said the book is not available until the end of November on Amazon.
Oh, okay. Well, that's interesting. I didn't know that. You can go to the amazon.com.au website, and they have it because a friend of mine in the UK bought it off there. So if you're really keen, you can go there. But otherwise, end of November is okay. All right, I'll bring up the slides. Okay. So as I was saying before, Emma, I don't really want to sort of, do a death by PowerPoint kind of presentation, but there are a few things, at least functioning as a memory aid for me, that I think it'd be worth having a discussion about. And just interrupt me at any stage if you want to digress or whatever. But so I'm just going to talk a little bit about the, prevalence of dementia and just sort of draw attention to something, on this world chart here. And you can see, sure, everyone knows where Australia is. We're down the bottom right there. but you can see that really the red patches are where dementia is the most prevalent. So essentially westernized societies. And really the reason for that is predominantly because those are the populations where we have the most elderly people to a certain extent. And you'll notice, interestingly, that places like Japan, who have a lot of elderly people as well, they don't have such a high prevalence, and there are possibly kind of genetic or lifestyle reasons for that. But Australia and the UK are kind of in the same sort of categories as North America as well. So it's a very, significant global problem, and just as much of an issue here as it is over there. To give you an idea of the actual numbers, so these are, you can sort of see in the middle of the chart here where we're at to now. I think the most recent figures are 472,000 people with dementia, so almost 500,000 in Australia. And then, like everywhere else in the developed world, because everybody's getting older, we're likely to see that figure go up. And I think in Australia, they say that maybe by 2050, our figures are going to double. In some parts of the world, it's going to be even more than that, unless we find a sort of substantial intervention, I suppose. So big numbers. The bit down at the below point there, the dark blue is young onset dementia. So there's not much suggestion that that's increasing. So that's a different sort of condition in a way, but it's the other one, the increasing prevalence is driven by age predominantly. Just switch to the next one. Okay, so I thought it'd be worthwhile just talking about a few myths, and again, writing the book. I mean, I talk in the introduction about how there is this lack of knowledge about Alzheimer's disease and dementia in general, and going along with that, there are these myths that exist, and the book is trying to sort of dispel some of these things as well. And your listeners and viewers may well be aware of this, but just to draw the attention to the fact that when we talk about dementia, it's not actually a diagnosis itself, it's a description of clinical symptoms and signs relating to a problem with thinking. But being told you have dementia is not a diagnosis. The diagnosis really comes from the cause. And most people, of course, have heard of Alzheimer's, which accounts for the majority of dementia, particularly late onset dementia after 65. And then vascular dementia as well, to do with blood supply and so on. So those two probably account for the lion's share of different causes of dementia around the world, and including in Australia. You're probably aware, but there's probably more than 100 or maybe 200 causes of dementia, but there's a handful that sort of cause the majority. And then there's Lewy body dementia, which you talk about if you need to, but sort of similar to Parkinson's. And then I should say temporal, not temoral, apologies for that, but frontotemporal dementia is there as well. And one thing that's not actually on this slide, which I sort of just borrowed from the internet, but which is relevant, I think, is alcohol-related dementia. And that's something that's really on the rise here as well, and particularly with the younger onset dementia. I think, we just consume more and more alcohol, and that's becoming a problem. So those are the five, the four there, plus alcohol. So dementia is not just Alzheimer's disease, it can be a number of other things, and that's important to pick up. So dementia can affect all the kind of different areas of the brain. So here you're seeing the cortex, so the outer sort of wrinkly layer, and we have 4 lobes on either side of the brain, and each of these lobes does different things. So the temporal lobe, the one in purple there, is the one that's classically affected the inside of that in Alzheimer's disease, and hippocampus, which you've probably heard of, as a small structure in there which affects memory. So that's your classic late onset dementia of an Alzheimer's type. But then you can have the frontal lobe affected in frontotemporal dementia and alcohol-related dementia fairly early on, as well as the temporal lobe, and that can cause different symptoms again. So the frontal lobe might cause problems with organisation and planning and personality changes and so on. So you don't really see much memory or cognitive problems initially, but you see the frontal lobe issues. And then parietal lobe, sometimes in the younger onset dementia, we see predominance of issues at the back of the brain here, so something called posterior cortical atrophy, where the parietal lobe is affected. And actually what we see is problems with movement, praxis and so on, and also visuospatial kind of issues. And then occipital lobe, less commonly affected, but sort of initially at least, but is responsible for kind of visual perception. So you can kind of see how all of these different lobes can be affected by different disease processes and they can cause different symptoms. And then, so they're all, I guess, those lobes of the cortex, as I say, they're the cortical region. And then below that is the subcortex. So that's just called the deep structures. And they can also be affected in dementia as well, different types. So typically, Huntington's disease is the classic subcortical dementia where you've got a lot of movement problems. But most people have heard of Parkinson's disease probably more commonly. And that's a subcortical type dementia. And with that, you often see movement problems initially rather than necessarily kind of cognitive problems. And Lewy body disease is a sort of mix of those subcortical problems and cortical problems. So again, different parts of the brain produce different symptoms. So in Alzheimer's disease, as I mentioned, the hippocampus is affected. So this is, if you imagine if you're having an MRI or a CT scan, and this is a section sort of cutting, let's just say, from one ear to the other ear. So let's just say you're kind of looking forward and that's the slice you're getting. This is just a sort of mock-up of what you might see. And these areas on the left and right in blue here are called the hippocampi. And you see this kind of loss of volume, as we call it, which is sort of to do with the early Alzheimer's process. And that it's damage to that area that causes that classic problem with short-term memory loss, requiring new memories and so on. So that's what we see in typical late onset Alzheimer's disease. Vascular disease is a different thing again, so to do with blood supply, as I say, so all the kind of things that affect your heart can affect your brain as well. And vascular disease can be affected by things like strokes and blood clots and so on, and can spread to various different parts of the brain and cause different symptoms depending on where it's affecting. And there's this, we're increasingly realizing now that there's this relationship between vascular dementia, or at least vascular disease, and Alzheimer's disease. They both seem to be risk factors for each other. And in my experience, that the vast majority of people over a certain age, 80 or 85, have evidence of both problems, vascular and Alzheimer's disease. So getting a pure Alzheimer's type disease dementia is very rare, and some people actually even refer to it as a unicorn. It's that rare, particularly in late onset. And then we've talked about the hippocampus, the subcortical dementias, and the basal ganglia, as I mentioned here. That's the Parkinson's sort of area that's affected, but lots of other areas can be affected as well. So I guess that just gives you an indication of the different areas of the brain that can be affected and the different symptoms that you might get depending on that. So it really isn't just, you can have dementia and not have memory loss. And that's something that a lot of people were, I guess, puzzled or surprised about when they would come to see me. They would say, well, I can't possibly have Alzheimer's, can't possibly have dementia because I don't, my memory's okay. And it's unfortunately not quite like that. I suppose we've covered this. So this is the second myth. It's all about memory, and it's not, because there are lots of other things that can kind of go wrong cognitively, and those things might dominate the picture rather than memory, at least early on. And it's not just that it's not only about memory as a cognitive problem, it's also involved in other things which you'd be very well aware of. Behavioural and psychological changes are very, very common. And then there are physical changes, particularly later on in Alzheimer's disease as well. And it's really important, I think, to recognise these things, because they often actually cause much more of a difficulty for carers, and indeed stress for the person with dementia themselves. So a lot of people seem to adapt to changes in memory function and cognition, but then if you're seeing your loved one anxious or depressed, or even not sleeping well, or even, unfortunately, in some cases, developing sort of delusional ideas and so on, that can be really hard to deal with. So recognizing that can happen and knowing that you can deal with it, I think, is really critical. So that's the second myth. This is just a slide about how Alzheimer's disease spreads. So I think as a lot of these different causes of dementia develop, we do see this progression of symptoms. So Alzheimer's disease, you'll see the preclinical on the left there, which basically means there is some damage to the brain, which we can now see on scans even before we actually see any symptoms. So that's preclinical. And then when somebody manifests the symptoms of Alzheimer's disease, we can see increasing damage as time goes on, and to a point really where eventually it affects all the different parts of the brain and lots of different cognitive functions become affected. The preclinical side, I mean, that's actually really interesting and promising in the sense that we now, of course, have the technology to see, particularly for Alzheimer's disease, some of the proteins, the amyloid and tau in the brain many years beforehand. And we'll come on to the importance of that, but I think that's something that's really hopeful, actually. You can sort of pick it up way before it becomes a manifest problem. So the third myth, again, I would see a lot of people and they would come to see me and they would say, well, I didn't come to see you before because there's nothing you can do about it anyway. You know, it's just what it is. And a lot of my work is actually about partly just correcting that, I guess, false information about things, but also reframing. And there's no point sugarcoating things. I mean, it isn't a curable condition in general. We don't have treatments yet that can do that. We do expect deterioration as time goes on, but there are lots of things you can do either to kind of help manage the cognitive losses or indeed address some of the other issues. So that's a lot of my time is spent focusing on, well, what can we do? You know, yes, you have dementia. This is what we think is going on. What do we now need to do? And again, your listeners would probably be aware of this, but there are a couple of types of treatment that we do use, particularly in Alzheimer's disease and vascular disease. You'd be familiar with these, Emma, so the cholinesterase inhibitors and memantine, yeah. So they don't cure, but they can be appreciably helpful for some people. I've started a lot of people on these now, and although the studies suggest modest benefits in general, I've seen people who have significantly improved, you know, to the point where they recognize their memories got better, and they also can be helpful in managing those other changes, the psychological changes as well. So I have a low threshold for using these if it's safe to do so. The reframing element of things is about, as I was saying before, acknowledging there are things you can't change, but focusing on things that you can. And also acknowledging that even though you may be diagnosed with dementia, you could still have, you know, 10 or 15 years of good quality of life. You know, it's not the end of the world. And I've seen this personally. I've known people who were diagnosed with dementia in, you know, the early 2000s, and obviously there have been changes, but they are still doing okay on the whole. You know, they're still happy and so on. So I think that's an important thing to recognise. Treating behavioural and psychological changes is important. We mentioned treating physical changes, pain is a big one, immobility and falls, continence, or things can be done about all of these, addressing legal issues, and then this huge issue of helping the carer function as a carer and making sure that they look after themselves. So I think there are actually a lot of things you can do to help manage it, and really that's the message I just sort of try and get across, I guess. So I won't dwell too much on these, but these are sort of just some of the examples of psychological and behavioural changes. So we see anxiety, and the Godot syndrome is when there's a shadowing kind of effect. So somebody with dementia might be following their partner around, just saying what's happening now, what are you doing today, etc. So it's a manifestation of that. But mood changes, anxiety, sometimes these false beliefs about things, and then some behavioural changes. So they're very common, but I really, as I say, emphasise that they are on the whole very treatable, and that's the thing to acknowledge. Carer stress. So in the book I talk about all these different things, but I do focus specifically on carer stress as well, because I think this is a huge problem for a lot of people. There are some, I think some people that take offence at the use of the word care stress or care burden because they feel that it's demeaning, and I certainly don't mean it in that way. And I really, I guess I'm just acknowledging the impact of somebody having dementia on their loved one, and I think it is a very stressful thing for them. So, and I think unless you acknowledge that, it's going to be tricky. So we know that carers have high rates of things like anxiety and depression and physical illness. You know, the carers have high rates of dementia itself, and that's possibly a stress-related thing. But lots of things can influence carer stress positively or negatively. So knowing everything you can about the disease, and hence again the book, but all of the education that you're doing and things is fantastic. The more we know about something, the better. Getting supports in place is critical, and isolation is, although it's a sort of almost an understandable reaction, people go into themselves and they worry about being around other people and telling people and things. That's a real problem. So anything that can be done to destigmatize dementia is really helpful. Carer stress is also influenced by behavioural and psychological changes as well, hence the need to address that sort of stuff. So I think there's lots of things can be done about carer stress. And then the next section, I don't know whether there's anything you wanted to mention at this stage before we move on to, but the next section really is about kind of more prevention style, because I think there's a lot of optimism in that space as well. Do you want me to go on to that? There's a few more slides on that. Oh, sorry, you're muted, Emma. Oh. So I can't hear you, actually.
Can you hear me now?
Oh, yeah, got you now. Yeah, lovely.
The dog knocked my microphone.
It was a gamble.
The dog. It was the dog.
Yeah.
It was right next to my screen. I was nodding away when you were talking about carer stress. I was thinking most of our work is around that space around carer stress. So the communication course that we deliver, that's proven to bring stress levels down, because if they can improve, if people can understand more what's going on and their communication improves with the person with dementia, then their stress levels can come down. And certainly the one-to-one support that we do with empowered carers is about bringing stress levels down and just empowering carers to continue caring for much longer. So I was sort of nodding away at those points, definitely. But no, yeah. Please carry on.
Yeah, and actually, thank you. And when you mentioned that about communication, that's something that I probably shouldn't have not put on that slide, because you're quite right. And actually, there is a chapter in the book again, which is just on how to communicate with people suffering dementia at different stages. How to best optimize that. And there's, as you're alluding to, there's a lot that can be done in that space. So that's critical, I think. So. Yeah, so the next little section, one of the myths with dementia is, it's just a disease of old age. And it might sound funny to say that it's not, but my point really here is that the roots of dementia are actually very deep. And so the changes that we see in terms of brain pathology and damage occur potentially decades before we actually see the clinical symptoms and signs. So as this slide says, it's not just a disease of old age. So this is probably, this first slide here is the general perception of things, that it's something that affects you maybe 60 and onward and all the rest of it. And of course, that's when you see the symptoms, so that's understandable. But in fact, this is probably a more accurate way of looking at it, because the problems and certainly the risk factors that we can address to try and reduce the chance of dementia, they should be ideally started earlier rather than later. I should hasten to add that it's never too late to start these things. I think they could always have some benefits, but we know that you can get a lot of traction by sort of addressing midlife kind of issues. So the next few slides, we're just going to talk about some of those what we call modifiable risk factors, so things you can change that can influence your risk. So that comes on to this myth, there's nothing you can do to stop it, which is, I think, not true as a general rule. Of course, sometimes it's just bad luck. Sometimes you can do everything right, and just like somebody might get heart disease or cancer, and they have the healthiest lifestyle. Some people, of course, can just have dementia, and I always try to mention that, because sometimes people can almost feel guilty that they didn't do all the right things to prevent it. It's almost as if it's their fault, and of course it's not. But this point really here is that we now know that a lot of things can be altered and changed, which can reduce or at least push back the diagnosis of some form of dementia by an appreciable amount. And even if you are destined to get dementia, if you can get it at age 85 rather than 75 by addressing these things, I mean, that's a huge extra decade of good quality life potentially. So are you familiar with this infographic? It's sort of doing the rounds globally, really, from the Lancet. So this was a study or commissioned report from last year in their sort of British medical journals of the Lancet, and it identifies a lifespan of different risk factors. So from the top there, you can see in early life, the biggest thing really is not having adequate education. And we know that people that have good education or even have cognitively stimulating jobs throughout life are protected, probably because of better cognitive reserve. And then as we go into midlife, there's a lot of different risk factors. So hearing loss, this often surprises people. And I think this is something that was kind of picked up for the first time in this report. There was one done a few years prior, which wasn't so obvious. But hearing loss is a big modifiable risk factor. Traumatic brain injuries, you'll probably be aware of all the issues to do with playing football over there and so on. Here we have AFL and we call it soccer, same thing. But that's an issue. So traumatic brain injury is a problem. And then vascular things, blood pressure, managing weight. Although these figures might seem small in terms of percentages, they actually, if you think about the amount of people with dementia globally, about 50 million, I think that they contribute a lot. So being overweight is a risk factor, drinking too much alcohol is a risk factor, like I mentioned. And then there's a whole bunch of things later in life. And these aren't exactly partitioned, that one stretches into the other. But things like smoking, mental health, we talked about isolation, we talked about lack of physical activity is an issue, and then diabetes and so on. So across the whole lifespan, there are things that you can do to reduce your risk. And I think it's good to pick that up. So in the book, I came up with this acronym. I like sort of playing around with words. So I'll just go through this. So the next few slides talk about these things in a bit more detail, but essentially there's about stress management, sleep, physical exercise, vascular health, friendships and socialization, hearing loss, complex mental activity, alcohol, and having the right diets. So these, I guess, to me, are the things that you can do. So we've talked a bit about mental health and dementia, and one of the things that we now recognize is that problems with depression and anxiety cause chronic inflammatory changes, which seem to then contribute to the risk of dementia. And the more severe and repeated your episodes of depression are, the higher your risk of dementia and so on. So there's definitely this link. And that hippocampus structure that we talked about earlier on in Alzheimer's disease is also affected by depression. So if you're depressed, there's a good chance your hippocampus is going to be smaller. And then if you treat the depression, the shrinkage in volume is reversed. So it's a really potent thing to kind of recognize. So very important to manage your mental health. And we've talked about that complicated relationship there, but people definitely should be doing what they can to manage that. I should point out here as well that when I'm talking about anxiety and chronic stress, I'm talking about the more severe end of things. So I'm not talking about just everyday problems and the stress that we all have. I've got 3 teenage kids, for instance. I'm hoping that might be a risk factor, that sort of thing. It's more the severe end of things that's a problem. And if there's any doubt, speak to somebody about it. Sleep. So sleep's really interesting. So sleep, there are different stages, as you're probably aware, and it seems to do different things to the brain. So it can help consolidate memory. So we sort of replay events. So we sleep, and that can help with brain function and laying down of memories. And then in the last decade, we've increasingly realized that the deep stages of sleep, which if you look at that graph up the top there, you can see the lines go down, particularly at the beginning of the night. That's your kind of deep sleep. And there's this sort of brainwashing effect where the system called the glymphatics kind of essentially washes fluid through your brain, gets rid of amyloid and tau and all these inflammatory molecules. And so it's a really helpful thing for our brain. And if we don't sleep well chronically, that can be a risk factor and probably related to these things. So another thing to address. Exercise. So I think that out of all the different interventions, it's a bit hard to know the hierarchy with these things, but I think exercise would definitely be up there in terms of something that we all need to be doing. If we don't exercise, we don't move, then we're really going to suffer for it. And it helps our vascular system, helps our mental health, sleep, etc. And it also generates these neurotrophins, so BDNF and so on, that help the brain grow. So we should be doing regular aerobic exercise. We should be doing resistance training, so using weights and so on. There's some evidence that high intensity exercise is particularly good. And then NEAT, that stands for non-exercise associated thermogenesis, which is another way of just saying incidental exercise. So we should be doing that as well. And of course, that's what we spend the vast majority of our day, not in formal exercise. So we should certainly be tackling that. Vascular health, we've talked a bit about. So the brain uses 20% of our energy demands, despite only being 2% of our body weight, and is therefore very sensitive to changes in blood supply. So managing all your vascular risk factors, blood pressure, cholesterol, blood sugar, etc., is critical, particularly in midlife, as we mentioned before. And food, so I mean, the diet and dementia link is huge, and we could talk about this at great length, but I guess suffice to say at the moment that the diet that we all know is good for us, Mediterranean diet, is good for our brain as well. There is this variant called the MIND diet, which is an acronym, which is a bit more specific, but they really all just essentially give you a diverse range of nutrients. Fiber is particularly important for our microbiome, our gut health, which again influences inflammation and dementia risk. Very interesting research in that field. We need omega-3 fatty acids. We should try and minimize saturated fat. There's some controversy about ketogenic diets and fat versus carbs, but I think the weight of the evidence suggests we should be minimizing it. And we're allowed to drink a bit of alcohol, which is a good thing, so, but not too much. And sugar and processed foods we should reduce. And sugar really is a killer. And I'm kind of realizing this, more and more. We live in a world that's kind of cursed with ubiquity rather than scarcity. We're naturally designed to seek out rich energy sources and things that will give us an immediate reward. But it's helpful when there wasn't much of it about, but when it's everywhere, it's hard to stop ourselves. So that's a real problem, I think. Oh yes, there you go. So I've got a slide on it. So it's something that I really try and address with my patients. This is, some people call Alzheimer's type 3 diabetes because of this link between blood sugar changes and insulin resistance and so on. And then fat, we talked a bit about as well. Hearing loss. So why does hearing loss lead to dementia? We don't really know. So it might just be that the same area or the same damage that's causing Alzheimer's or something else is also causing damage to the auditory cortex, so we don't hear as well. It might be that we are using more of our brain to hear and therefore underutilizing the rest of the brain, and therefore that's not helpful. Or it might just be that we're becoming isolated because we can't hear people around us. So there's lots of kind of potential relevant factors. And there's some research looking at addressing hearing loss within cochlear implants or hearing aids and how that might help. Mental activity. I was listening in on another one of your webinars the other day where you had a lady, you were talking about cognitive and brain reserve, and then I think social and emotional reserve, which was really interesting. But she touched on cognitive reserve, which we know is the ability of the brain to essentially withstand the damage and allow us still to function. And using your brain reliably sort of over the years is one good way to build up cognitive reserve. Neuroplasticity is a similar kind of concept. If you're using your brain continuously, it's helpful to rewire the brain literally. So we need to be doing complex things that are slightly stressful but not too stressful. We need to do things that our brain is not used to, and we need to be doing progressively more difficult things. Then there's the area of brain training, which is controversial. You can come back to that if you like. Alcohol, complex relationship. As I said before, we can't say that if you're otherwise healthy, you've got to be teetotal. There's some suggestion that if you drink a little bit, it might actually be beneficial. We're not sure. The only certainty really is that if you drink too much over a long period of time, you will do your brain some damage. And there's a lot of countries around the world that don't even give guidelines on alcohol consumption, because even if it may not be necessarily bad for the brain, it's bad for other health conditions, and so they don't see any safe level of drinking. In Australia, our recommendations recently are not to drink more than 10 standard units a week, so that's a little bit more than a bottle of wine, and not more than 4 in one sitting. So I would imagine the UK, often we're quite similar with these things. And then finally, nurturing friendship. So we've talked about isolation that can happen when you have dementia, when your loved one has dementia, but even before that becomes a problem, social isolation and loneliness are problematic, and they're different concepts, and your listeners may well be aware of this, but social isolation is obviously not having enough people around you. Loneliness is a feeling, and tragically, actually, I think a lot of the loneliness that I see in this country is actually in aged care facilities where there's lots of people around, but there's a difficulty connecting to people. And so that's just as problematic as not having people around at all. And again, there's this sort of inflammatory sort of process that takes place when we're isolated or feeling lonely, and that's a risk factor for dementia. Okay, so that is the end of the PowerPoint. I'll stop sharing.
Brilliant. I could not imagine that you were going to give us that amount of information in quite a short amount of time. So well done. You've done well on it. You've done well.
Okay.
Okay, so we have 10 minutes now for Q&As. I suppose what I really liked about your presentation there, Kailas, is that, that feeling that we can do something about it, because I think people often think, well, if you're going to get it, you're going to get it. And I think that is still sort of most people think that, but trying to get that message out that actually, a healthier lifestyle in your midlife will actually reduce your chances in your later life. So I think that's a real positive message to get out, and it's something that we should all, just be embracing. No,
I definitely agree. And we have that added challenge that it's hard to do things that are not very appealing now to stop something happening 30, 40 years down the track. So there's that kind of behavioural change issue. But most of the things that help with prevent or delay dementia are good for us now, and we feel better for it. So that's something to take on board. Yeah.
Definitely right. Tony has got the Kindle version of your book and is enjoying the web conversation. Brilliant, Tony.
Oh, great.
I felt like you just put them all on with a challenge. Right, Kellen has said, I'm really interested in the use of medication in dementia care, particularly in long-term care facilities. There's been a long-standing issue of a tendency to use antipsychotics in dementia care when a person presents with behaviours that others find challenging. I also saw this in my research. My research focused on everyday objects and identity. There is a conversation with Kellen Lee, if anybody wants to find it, supporting people to use everyday objects to complete often mundane tasks, and how that could reduce the introduction of medication reviews, reduce distress and anxiety in both person with dementia and staff. My question is, as a medical doctor, do you think this could work in a hospital setting? So Kellen's very much about like your normal stuff. So the mug that you would always have your water with, or the deodorant that you're very familiar with. So all of those familiar things that we just take for granted, actually quite often when you go into a care setting, they're stripped away. So that familiarity is lost. So she's saying, if that was introduced into a hospital setting, do you think that we could reduce the amount of medication because people would just feel more comfortable because they're drinking the tea out of their normal mug, those sort of things?
Yeah, look, I think that's a great idea, and I can see absolutely no reason why it wouldn't work in any kind of clinical setting, I suppose. And in psychiatry, we have this concept of a thing called a transitional object, which is something that you take when you're moving from one place to another that gives you that sense of familiarity. So as a child, often they have teddies, and so you might have a teddy and you're going to something new and you take your teddy with you, and it's kind of like this safety thing. So as humans, we have this very innate need to kind of have familiar things around us. And so these kind of objects, I think that's quite right. They can potentially be very helpful in that respect, and they're also somewhat grounding and orienting as well. So I think in that respect, that could be very beneficial. And I must say, like a lot of the aged care facilities in Brisbane, I'll go and I'll see somebody that's been there a couple of months, and I walk into the room and there's nothing there, and you think, where are all their personal possessions? And they might be agitated or unhappy or whatever. And you think, well, there's some simple potential fixes here. So yeah, I think it's a great idea.
Brilliant. Hey, I feel like you've been pushing your book because someone else is asking a question about your book now. Does your book, Kailas, expand on the acronym you showed in the slides, and especially the mind diet?
Yeah, it does. So there's a chapter that's just about, I guess, that brain scan acronym, and talks about the different things that you can do. Funnily enough, actually, all the sort of interviews that I've done, I would say 90% of the focus has been on people have been interested in prevention rather than all the other really important stuff in the book. And the book is, I would say, maybe 10% of it is on prevention, and the rest of it is about the assessment process, about treatment, and so on. So yes, it definitely does go into some detail about the brain scan acronym and things, but there's other stuff in there as well, I suppose.
And we certainly find that, you know, we work with around dementia all the time, and you're just more alert to it, aren't you? You're more alert to, like, if I can't remember somebody's name or remember where I know them from, is that an early sign of dementia? And it's just because of the field that we work in, and also for carers, you know, they're going to be like very alert to what might be going on for themselves. You know, they're caring for somebody with dementia 24/7 potentially, and they're going to be very aware of what's going on for themselves. And Michael's asked the question here. He said, is interested but also alarmed at the mention of the increased link of dementia to carers. Is this triggered by familial genes, as most carers are relatives to the patient, or is this an external trigger through associated mental illness, stress on the carer? In which case can this be addressed?
Yeah, so I think the thought is that it's the latter. So it's not a genetic thing. You know, often we're actually talking about husbands and wives rather than necessarily adult children. So the genetic link is, I guess that's another conversation. But the thought is that the stress of acting as a carer can cause its own problems, whether they're mental health problems, whether they're inflammatory kind of changes, whether it's, you know, isolation and so on, and even all these other physical health problems that can lead into dementia. So there's definitely, I believe, some scope to reduce that increased risk by recognizing carer stress, putting supports in place, educating people, and dealing with all that kind of stuff. I'm sure that would bring the rates down.
And Kellen's just commented on that as well. She says, I was wondering the same thing. Carers often feel isolation and loneliness. So I wonder if this can increase the risk as well.
Yeah. So both of those, like I mentioned on the slides there, we can do blood tests that show the levels of inflammation in the body are raised when people feel lonely or when they're isolated. And inflammation just seems to be this undeniable risk factor for dementia later on. So a lot of the causes of dementia, I think, are possibly driven by sort of inflammatory processes, and social isolation and loneliness cause that as much as anything else.
Right. The chat is going busy now. It's getting busy, mainly by Claire. Thinking of genetic links, if you're a daughter, son, etc., caring for a parent, what are your thoughts on testing young family members?
So I think it obviously depends on the individual circumstances, but it does also depend on the age of onset and the amount of family members that have dementia. So what we know is that there is a risk with a gene called ApoE in later life dementia, particularly Alzheimer's disease. If you have 2 copies, your risk of Alzheimer's disease does go up quite substantially. But still, the thought is, in general terms, that the other risk factors might be just as relevant. And it's important to know that you can have the problematic gene ApoE4 and not get dementia. And a lot of people have dementia and don't have the ApoE4 gene. So I think there is a link genetically, but if you have one parent who developed dementia, say in their mid-80s or so, I really wouldn't be overly worried about the genetic link. I would just be focusing on the other things. If, however, you have, 1 or 2 or 3, family members, close family members who've developed dementia earlier in life, by which I mean, in your 50s or 60s, then there's possibly going to be a high genetic element to it. And then I guess you have to decide whether you want to know whether your risks are there or not. And the genes underpinning those kind of younger onset dementia are a bit different. We know about 3 in particular that seem to increase the amount of amyloid in the brain. And so it's a slightly different process, I think, to the late onset dementia. So late onset, 1 or 2 relatives in their 80s, I wouldn't worry about it. Multiple family members in your 50s, yes, it's probably more reason to do it. Yeah.
Brilliant. And Kellen just asked a question, can you get those tests from a GP? So that was the tests around loneliness and isolation that we were talking about, that you can spot how you can see that physically they're lonely or they're isolated. You can see that. Would you say was it inflammation? Inflammation,
yeah. Yes, you can. I mean, in England, and I haven't worked in medicine in England for a while, but when I used to work there, we used to get these 2 tests called CRP and ESR, both of which are inflammatory markers, and I'm sure you can probably still get those through a GP. There are a number of other, I guess, less well-known inflammatory markers, which are probably more generally used in research processes, but those basic kind of tests, you can get a sense of whether you have bodily inflammation. Yeah.
Brilliant. I'm just going to set off the polls so people will be able to tell us how they found today's conversation. I've got a very important question in the last few seconds of our conversation this evening for you and this morning for us. What was it about working in Bolton for 6 months that made you decide you wanted to go to Australia?
Actually, I didn't mind Bolton, but my work was all emergency work, and so every Friday and Saturday night I'd be dealing with people, falling out of pubs and clubs, and with no frontal lobe function. And I think after a while it kind of just something about those PowerPoint slides with the sandy beaches just convinced me in the end. So.
Okay, we've got our very last question. We are going to run over very slightly. So Dr. Michael Mosley, TV doc in the UK, you must have heard about him in Australia. He's gone everywhere, hasn't he? He's had a programme on Radio 4 earlier this year that looked at a simple trick of standing on one leg for 30 seconds to a minute each day, and it had a link to preventing dementia. I now practice this, but is this really true? I can understand about using balance and other parts of the brain simultaneously, but is there any research to back this up?
I would imagine if Michael Mosley says it is true, it probably is true. That's all I can say. I actually, I'm afraid I don't really know the research kind of behind that. Again, it's using your brain in a slightly novel way. So in that respect, it's good. But yeah, beyond that, I'm not sure about the research background to that, I'm afraid.
So Mike, carry on balancing on one leg. Clara said, this has been an excellent talk. Thank you so much. And I look forward to reading your book. Oh, they're all hitting the bookshops or Amazon in November to buy it. Right, Kailas, it just leaves me to say thank you so much. Rachel said it's a wonderful and informative conversation. Thank you.
Thank you very much. Well, it's been very nice to have a chat.
Oh, and thank you for your time. Thank you for just randomly agreeing to come and do this, even though, it was just a little comment on LinkedIn and you jumped on. So thank you so much for that. Can you remind me of the book name, please? Kellen's asked.
Yeah, so it's called, I'm just at home. I was just thinking I've got a copy of it here somewhere. Here you go. I don't have hundreds of copies. This is it. It's called Mind Your Brain, The Essential Australian Guide to Dementia. But as you said, maybe we'll change a bit of that at some point.
We'll just scrub out the Australia. Yeah, that's what you'll be buying. Okay, so our next webinar is a week on Friday. It's with Norms McNamara. It's a slightly different time, 10:30 till 11:30. He lives with dementia and he set up Purple Angels and runs World Rocks Against Dementia. So if you have time, come and join us for that one. Everyone is saying brilliant. Thank you so much. Kailas, they've all enjoyed it ever so much. And we've gone over by 2 minutes. We never go over by 2 minutes. And I think that's testament to how brilliant the conversation has been with you and how bad I am at time managing.
Me, unfortunately. Yeah. Okay.
Wonderful. Thank you. I'll let you crack on with your evening. Thanks, everyone. Enjoy your days. And I will speak to you all soon. Take care.
Thanks very much. Bye-bye.
Bye-bye.